Hello and welcome to Professor Gadgil's GPAT Academy. Today we will discuss about antiviral drugs. Before discussing, we will discuss some general principles about viruses. Viruses are obligate intracellular parasites. They hijack the host cell machinery. Antiviral drugs target viral-specific processes without harming the host cells. Unlike antibiotics, antivirals are generally virostatic, not virucidal. The challenges is that latency, resistance, and narrow spectrum. First are the anti-herpes agents. These are the guanosine analogues that require triple phosphorylation to become active. The first phosphorylation is done by the viral thymidine kinase, ensuring selective activation in infected cells. The triphosphate form inhibits the viral DNA polymerase and causes the chain termination. Acyclovir is the prototype. Its activation is via the viral thymidine kinase into acyclovir MP. The host kinase then converts it into the acyclovir TP. Spectrum HSV1, HSV2, VZV, which is less active against EBV and CMV. Resistance is via mutation in the viral TK or the DNA polymerase. Route of administration is oral, IV, or topical and has low oral bioavailability, that is approximately 20%. Key side effects are nephrotoxicity, that is crystalluria, and so hydration should be maintained. Valacyclovir, it is a prodrug of acyclovir. It has 3 to 5 times better oral bioavailability. It is converted to acyclovir in the liver by the first pass metabolism. Famciclovir, it is a prodrug of penciclovir and has high oral bioavailability. Penciclovir TP has a longer intracellular half-life than acyclovir TP but is a weaker DNA polymerase inhibitor. Ganciclovir has the spectrum of cytomegalovirus, which is the drug of choice. Activation is that it is first phosphorylated by the viral UL97 kinase in the CMV. Toxicity includes myelosuppression, as it is the major dose-limiting toxicity, much more severe than acyclovir. Valganciclovir, it is a prodrug of ganciclovir, an oral form of CMV. Zidovudine is a nucleotide analog of cytosine, already has an 1-phosphate and so it does not need viral kinase for initial activation. Spectrum is CMV retinitis, that is a second-line agent, and resistant HSV. Toxicity includes nephrotoxicity and hence must be given with probenecid plus IV fluids. This is its hallmark side effect. Foscarnet has unique mechanism of action. It is not a nucleoside analog and directly inhibits the viral DNA or RNA polymerase by blocking the pyrophosphate binding site. It does not require phosphorylation. Spectrum acyclovir resistant HSV, ganciclovir resistant CMV. Toxicity includes nephrotoxicity and electrolyte disturbances. Metabolically, it's a pretty dirty drug. Next class is the anti-influenza drugs. First is the neuraminidase inhibitors. They block the neuraminidase enzyme on the viral surface, preventing the cleavage of sialic acid. This stops the release of new viral particles from the infected cells. New virions remain stuck to the host cell. First drug is the oseltamivir. It is an oral prodrug and converted to oseltamivir carboxylate in the liver. It is effective against influenza A and B and must be given within 48 hours of symptoms onset. Key side effects include nausea, vomiting, and hence should be taken with food. Rare side effects include neuropsychiatric events. Zanamivir is an inhaled powder and is active against A and B. It should be cautioned in asthma and COPD as it can cause bronchospasm. Peramivir has the IV formulation and is a single dose for uncomplicated influenza. Next class is the M2 ion channel blockers, that is adamantins. They block the M2 proton channel of influenza A virus, preventing the uncoating and release of viral RNA into the host cell. Amantadine and rimantadine are only active for influenza A and are inactive against B. Amantadine crosses the BBB and hence have the CNS side effects like the insomnia and hallucinations. It is also used for Parkinson's disease to increase the dopamine release. Remdesivir has less CNS penetration. Limitations are very high resistance in circulating strains and no longer recommended as the first-line agent. Next class is the polymerase acidic endonuclease inhibitor. The drug is baloxavir marboxil. It is a prodrug. Active form is baloxavir acid, which inhibits the cap-dependent endonuclease, that is, PA subunit of viral RNA polymerase. It blocks the cap snatching mechanism and hence prevents the viral mRNA transcription. It is a single oral dose and active against influenza A and B. It is a newer drug and hence resistance is a concern. Next, we will discuss about anti-hepatitis drugs. First, we will discuss the drugs for hepatitis B. The class is nucleoside analogs, that is NRTIs for HBV. The drugs are tenofovir disopropoxil or disoproxil fumarate or tenofovir alfenamide. It is a first line for chronic HBV, potent and high barrier to resistance. TAF has less renal and bone toxicity than the TDF. Entecavir, it is a guanosine analog, also the first line, very potent, high genetic barrier to resistance. Lamivudine, it is used historically, but resistance develops rapidly, so no longer preferred as a monotherapy. Adifovir, it is less potent, nephrotoxic at higher dose. Next class is the interferon alpha. Mechanism of action is via immunomodulation, that is antiviral cytokines. It boosts host immune response. It has a finite course of 48 weeks and there is no resistance. Disadvantages include injectable, flu-like symptoms, and depression. Next, we will discuss the drugs for hepatitis C. Treatment is now direct-acting antivirals targeting specific non-structural proteins. The goal is a sustained virologic response which can cure the disease. Now we will discuss the drug class and target protein for the hepatitis C virus. Drug class is NS3 or 4A protease inhibitors. The target protein is NS3 or 4A, which cleaves the polyprotein. Next is the NS5A inhibitors. The target protein is NS5A replication complex. Next drug class is the NS5B polymerase inhibitors. The target protein is NS5B RNA polymerase. Next class is the NS5B polymerase inhibitors. The target protein is NS5B allosteric inhibition. And the last class is ribavirin. The target protein is immunomodulation and RNA mutagenesis. The key combinations, that is pan-genotypic for oral 8 to 12 weeks are Sofosbuvir or velpatasvir, which covers the all genotypes, and glicapavir and pibrentasvir, which has the 8-week course possible. Next, we will discuss the antiretroviral drugs. The target is the HIV life cycle, that is entry, reverse transcription, integration, protease processing, and maturation. Now we will discuss each class. First is the NRTI, that is nucleoside or nucleotide reverse transcriptase inhibitors. Mechanism of action is that it is a phosphorylated analog of native nucleoside and competes and cause chain termination, that is lack of 3'OH group. Next class is the NNRTI, that is non-nucleoside reverse transcriptase inhibitors. They bind directly to a hydrophobic pocket on RT, causing a conformational change, and do not require the phosphorylation. Next class is the protease inhibitors. They block the HIV protease, preventing the cleavage of GAG-pol polyprotein, and hence immature and non-infectious virions are produced. Next class is the integrase inhibitors. They block the HIV integrase, preventing the viral DNA integration into the host genome. Last class is the entry inhibitors. We have the Maraviroc, which blocks the CCR5 coreceptor and requires tropism assay. The enfuvirtide, that is T20, is a peptide and injectable. It binds to GP41 and prevents fusion, and hence it is a fusion inhibitor. Now we will discuss the toxicity for the antiretroviral drugs. Zidovudine has hallmark toxicity of bone marrow suppression, severe anemia, and neutropenia. Tenofovir has nephrotoxicity and decreased bone mineral density. Efavirenz has CNS toxicity, that is vivid dreams, hallucinations, and depression, and is also teratogenic. The protease inhibitors have toxicity of lipodystrophy, hyperlipidemia, insulin resistance. Atazanavir causes indirect hyperbilirubinemia. Nevirapine has severe hepatotoxicity and Stevens-Johnson syndrome. Abacavir has fatal hypersensitivity and requires absolute screening for HLA-B5701. Didanosine has pancreatitis and peripheral neuropathy. Now we will discuss the anti-RSV, that is respiratory syncytial virus. Ribavirin, that is inhaled formulation, is used for severe RSV bronchiolitis in children but teratogenic, so caution with aerosol exposure for pregnant healthcare workers. Palivizumab is a monoclonal antibody against the RSV-F protein. It is used for prophylaxis and not treatment and is given to high-risk primates. Next is the anti-SARS-CoV-2, that is COVID-19. Remdesivir, Remdesivir, it is a nucleotide analog. It is a prodrug and it terminates the chain at viral RNA-dependent RNA polymerase. It is given IV. Its role was re-established during the pandemic for hospitalized patients. Nirmatrelvir or ritonavir are oral formulations. Nirmatrelvir is a SARS-CoV-2 3-CL protease inhibitor and blocks the main protease MPRO. Ritonavir is a PK booster and is used for high-risk patients and should be given within 5 days of symptom onset. Molnupiravir is oral and ribonucleoside analog of cytidine. It induces viral error catastrophe, that is, lethal mutagenesis. It is less effective and reserved when alternatives can be used. There is a theoretical risk of mutagenesis in host. Now we will discuss the pharmacological interception matrix. Acyclovir has HSV and VZV virus target. Core mechanism is chain termination and hallmark toxicity is nephrotoxicity. Ganciclovir virus target is CMV. Core mechanism is requires viral UL97 kinase. Hallmark is severe myelosuppression. Foscarnet virus target is HSV and CMV. Core mechanism is it blocks DNA pol pyrophosphate site. Hallmark is electrolyte imbalance and nephrotoxicity. Oseltamivir virus target is influenza A and B. Core mechanism is Neuraminidase inhibitor and hallmark is effective only if given less than 48 hours. Amantadine virus target is influenza A. Core mechanism is M2 ion channel blocker and hallmark is CNS effects and is used in Parkinson. Sofosbuvir virus target is HCV. Core mechanism is NS5B polymerase inhibitor and hallmark is essential backbone of HCV cure. Tenofovir virus target is HBV and HIV. Core mechanism is NRTI chain terminator and hallmark is renal toxicity and decreased BMD. Zidovudine virus target is HIV. Core mechanism is NRTI chain terminator and hallmark is bone marrow suppression. Efavirenz virus target is HIV. Core mechanism is NNRTI binds RT directly, while hallmark is vivid dreams and teratogenic. Dolutegravir virus target is HIV. Core mechanism is integrase inhibitor and hallmark is first-line regimen and high barrier. Nirmatrelvir virus target is SARS-CoV-2. Mechanism is 3-CL protease inhibitor and hallmark is requires ritonavir boosting. That was all about antiviral drugs. If you like this video, do like, share and subscribe. Download our GPAT Pro app from the Play Store for such exciting content. We have bundled 3 packages with 10,000 plus MCQs, 100 plus video lectures and competitive exam specific notes. That's all for today. Stay tuned for next video. Professor Gadgil signing off.